So welcome to this edition of the Pensions, Retirement and Aging seminar. Before we begin the proceedings, I would like to acknowledge the traditional owners and custodians of country throughout Australia and their continuing connection to land, waters and culture. I pay my respects to the elders past, present and emerging and extend that respect to Aboriginal and Torres Strait Islanders who are present here today. So just a couple of ground rules. I think I muted anyone who wasn't muted. Please be just muted during the presentation. And if you have a question, use the raise your hand function or the chat box just to let me know that, that you have a question. And we will have a Q&A break or a Q&A section where I will moderate the questions. So now it's an honor and a pleasure to introduce Vas to you, Vas Yiengprugsawan. She has a PhD in epidemiology, economics, and population health from ANU. She has worked, for example, at the UN International Organization for Migration. She also was awarded the WHO Asia Pacific Observatory Fellowship, where she focused on health system and the responses of the health system to population aging and some non-communicable diseases in Asia. And she's now a senior research fellow at CEPAR, actually already for quite some time. So Vas, the floor is yours.
Thank you very much, Inga. Good afternoon, everyone. Thank you very much for joining me today. So in this session, I'll be talking about pain and functional health based on our data in Indonesia. Just a bit of background with the context for the study. So the study is part of CEPAR, UNSW Node, and also the UNSW Business School Aging in Asia Hub. So we have started this work about a year ago, and with John and myself at CEPAR, UNSW, Bob and Fiona at University of Sydney. And we also have a collaborator, Firman, who's a demographer based at ANU. Firman has been working with this data set for over 10 years, so he could really provide us the insight into the data. So it's just a bit of a background that, so I have started a research on pain about 5 years ago, and that was really when I started looking at the low back pain and the impact on Thai workers. And after a couple of years after that, I did an endeavor fellowship at UCL, and we had a chance to look more into persistent pain in more sites, not only low back pain, but also knee pain and hip pain. So I'm really glad to have an opportunity now to pursue the pain research back in Asia, but with the relatively new setting for me, which is Indonesia. So just a brief outline of the talk. But I think mostly just to mention that qualifications during the presentation is welcome, and Q&As, we would have Q&A at the end. So just a little bit of a personal story. So while I was preparing this talk about a week and a half ago, I experienced sharp pain in lower abdominal. 6 hours later, my GP sent me to the hospital with a possible diagnosis of appendicitis. And of course, when you're at the hospital, the usual question you get asked is that on a scale of 1 to 10, 0 to 10, what's your pain level? And I think here we go again. And I just found this question quite interesting because I had no idea what the level 10 would be. So I always answer this in a tricky way, kind of change that scale and say, compared to what I have experienced at A, this is so-and-so. Also, I also want to check that during my time at the hospital, how many times would I get asked by how many health professionals? And the answer was 9. So there were 9 different health professionals from doctors and nurses that asked this question. And when I came back, and I got a comment on the slides from our co-authors, I think it was really important, the definition, but also how important is pain for each individual. So that comes with a definition by the International Association for the Study of Pain, which announced a revised definition that the pain is unpleasant sensory and emotional experience associated with or resembling that associated with an actual or potential tissue damage. But there are also a couple more clarifications, and 2 are really relevant to the study. So pain is always a personal experience that is influenced to varying degree by biological, psychological, and social factors. And a person's report of an experience as pain should be respected. Before I get into the context of the study, I might just start with Australia. And from my quick research, I've seen this very interesting piece by Deloitte, the Access Economist, about the cause of pain in Australia. And it's very, very large scale. So 3 million Australians are living with chronic pain. And these are more common in female and working age. And the cost of pain has cost Australians $73 billion each year. And a large proportion of that is from lost productivity, and 12 billions in health systems costs, and 12 billions in other costs, including informal care. So chronic pain also have effects on impact on quality of life. And I think this is quite very relevant. So now I'm going to start off in the international pain research overall literature first. So pain is, as I mentioned, that it's actually across lifespan, but also it's also quite increasingly common as people age. So as I mentioned, that also globally, pain, especially if persistent or chronic, have an impact on physical and psychological well-being, but also have implications for productivity, health services, health expenditures, and also social support systems. But for older persons, chronic pain is often linked to frailty, falls, fractures, and also limited social engagement and psychological distress. Pain in older persons is also complex because they often have other comorbidities, both in the form of physical, but also psychological conditions. So in recent years, there have been increasing longitudinal studies on impacts of pain on functional ability among older persons. But most of these evidence are actually more from affluent settings. So I just cite a couple of those that are quite relevant for this study. So the study on widespread pain, so across the body, and the impact on frailty. So for example, among European men, there's a site-specific pain, which is also quite important in the literature, on knee pain in incidental disability in Australian men. So this is from CHAMP study. And there's also a multi-site pain, which is also more common among older people, where they could have a number of sites simultaneously, and impact on mobility. Just to give a bit of background, that pain, the most common type of pain reported in the literature is musculoskeletal disorders. And according to the Global Burden of Diseases study of 1990 to 2017, this disorders has comprises the second highest cause of years of life with disability. But if you look closely at the 50 years to 60 years old, this is actually become #1 in both low and middle income countries. So what we look at here is a ranking of main causes of years lived with disability, and these are both sex in 50 to 69 years. So in the low middle income countries, low, middle, and high income countries, these are all quite high. And in particular, it's really the low back pain that attribute to this cause, followed by diabetes and COPD and other conditions. And these are sometimes actually happen at the same time, so hence the comorbidity in the older age group. So in Asia, there are more limited large-scale longitudinal evidence on the self-reported pain, and that's mainly because of data availability. So we have actually taken advantage of this data with our team, with the National Representative Indonesia Family Life Survey, and we'll be investigating the 7-year relationship between pain and impact on functional health among middle-aged and older adults in Indonesia. So our objective is to look at dynamic nature and the impact of pain, but also we will look at other comorbidities as well in later life. So in particular, we're looking at the research question of to what extent does pain status at 2 time points that we measure in 2007 and 2014 impact the functional health outcomes in 2014. A little bit of background of Indonesia. I think so. What I've done is I just compared to other countries. So Indonesia is have quite a large population base. It's almost 273 million people, and the population aging is at this stage is about 10% in 2020, but the trajectory is actually quite increasing quite rapidly in the next 15 years and also in the next 30 years also. And so it's a lower middle income country at this stage, and I think that's why for planning for aging population would be quite challenging. The other one that worth mentioning is also the nature of the epidemiological trend. So the life expectancy has increased substantially over the years to about 69 for male and 74 years old for female. And then the main causes of death, the majority now has been non-communicable diseases and much less now with communicable and maternal and child conditions. So as I mentioned that we use IFLS data, which began in 1993, that's wave 1, and this is an ongoing socioeconomic and health surveys, which is covering about 83% of the population. So IFLS contain both individual and household characteristics information from age, sex, education, and so on, but also both objective health measures and also subjective health measures as well. There's also information on healthcare utilization and health expenditure. So the two data that we'll be using, they're collected by Surveymeter, where Feynman was before, and supported by the RAND Corporation in the US. The household were completed by face-to-face interviews and also being measured for the objective performance as well. So the questions in the IFLS were harmonized, similar to other health and retirement study, including the China Health and Retirement Longitudinal Study and also the Longitudinal Aging Study in India. So just a few words about the IFLS. So as you can see from this map, that it's cover the 13 main provinces. So the dark pink is where it's being covered. The one that the main area that wasn't covered is this East Asia, Eastern region area, which actually in lower socioeconomic status, but they have a separate IFLS East Asia that cover that Eastern region. So the study that we will focus on is the latest two waves, which is wave 4 and wave 5 in 2007 and 2014. So there were the total of 19,000 responses in both waves and 7,936 that are aged 50 years and above. So we only use those that respond in both waves. So the response rate were 71% in wave 4 overall and 64% in wave 5. We noted that the dropout groups were more likely to be urban, more highly educated, and higher socioeconomic status. And these are because they actually move out of the area from rural area to urban, for example, and hence why the drop-off. So the main measure of pain that we used in the survey was first asked in 2007 in wave 4. So in the last 6 months, were you bothered by pain in your, and they can specify the area, and then how severe was the pain level. So mild, painful, or severe. So at the 7 years follow-up, this question were asked again with a slightly different categories of response. So do you feel pain? No, a little, somewhat, quite a bit, or very. And that's how we classified it into 3 groups, like a low, medium, and high. So repeated measure of pain were classified using this persistent, whether do they have this in both waves and what are the pain severity in both waves. There were also, as I mentioned, that questions about the specific body part that they can identify from head, neck, shoulder, and some part of the body limbs, and finger, back, lower back, hip, knee, legs, and ankle, foot, and toe. So the analytical approaches we use is a hierarchical multivariate linear regression. And we use this to analyze the association between pain and functional health outcomes, and we adjusted for a range of potential covariates. Population weights were used in the analysis. So I might just mention that the two main part of the ADL and IADL. Let me just say, I think that we missed one slide. Sorry. Okay, I have to do this one first. Sorry about that. So the outcomes and the covariates. So the subjective physical function measure that we use is 20 items of activities of daily living, and also the instrumental activities of daily living, which range from whether they can walk 5 meters, climb stairs, to dress without help, to bath, to shop. And these difficulties were ranged from easily, with some difficulty, and unable. We also use objective physical performance, which was measured by average grip strength in kilograms. So these are measured twice in each hand based on this spring type dynamometer. And the grip strength in the literature has been shown to be a predictor of old age, disability, and also a biomarker for functional ability in later life. So the main covariates that we used were age, sex, and socioeconomic status, geographical areas, and also some health attributes. One of the main one is the proxy of the comorbidities, which is number of chronic conditions. And depression was used as one of the to adjust for psychological distress condition, because depression was found in the literature as to mediate the relationship between pain and frailty among older persons. So the IFRS has the Center for Epidemiologic Studies and Depression Scale, SESD, the 10 items, with a score range from 0 to 30, with score of 10 and above as having depressive symptoms. So what I want to show a little bit is just how it works. So this is because we are looking at the relationship between pain and frailty, or in our case, it's functional limitations. But because comorbidities such as chronic conditions could actually link to pain and also the outcome, as well as the depression as well. So hence we adjust this in the analysis. I'm gonna go back to that one. Sorry, it was just a bit the order mishap. So yes, the analytical approach was a hierarchical multivariate linear regressions to analyze the association between pain and dysfunctional health outcomes of variables, adjusting for potential covariates, and a population weight were used. So the functional limitation scores, the higher it is the greater difficulties in performing these ADL and IADL. And you can see from this number that as people getting older in the 7 years period, the number generally increased. So they generally, everyone has a more difficulties overall. And the other measure we have was the grip strength, the one that I mentioned overall. And we look at the mean score. And this one over the 7 years, the number going down because people generally, as they get older, they have less strength. So the number overall is going down during the 7 years period. So now we'll be looking at some descriptive statistics for this. So this table is looking at the last wave of the data, and we're looking at dividing into two groups. So those that, the proportion of those that have severe pain, without severe pain and with severe pain, and by sample characteristics. For example, with here you can see that there are more proportion of female than male that having severe pain. There are more older groups, 60 to 69 and 70, that have a portion of severe pain, and these are significant proportion. Those are being widow, but these are also crude numbers, so could be because they're older as well. They're more likely to be widow. And having elementary school, having lower education, were more likely to be associated with having severe pain. There were no significant differences between the per capita expenditure group and geographical areas. But if we look at the proportion of severe report pain, I think this is also another way just to have a look, and it's confirmed what we've seen before, which is about more likely about 15. Overall, it's about 13% of older people, 58 years and above, that report pain, and it's about 15% among female. Again, you know, it's increasing with age, more likely in the middle, and a bit higher in elementary school. So again, so these are the exposure, which is the pain measure, and these are the outcomes. So I'm showing you again that compare between those that are without severe pain and those with severe pain, both of them over the 7 years period, they are also having a higher functional limitation as they get older. But you can see that the increase is quite larger among those that are having a severe pain group. And for the grip strength, again, as well, everyone's having a slightly less strength in grip strength, but for those that have severe pain, they're actually much higher the differences. Now we'll be looking at the reported pain site. And this one, I'm just looking briefly at the difference between male and females. In this one, females in particular are having a higher, the vast differences between male and female for reported back or lower back among female in particular, and also among knee pain among females. Also, if you look at the multi-site pain, female were also having a much higher, significant higher proportion among females that report this. So I'm just going to show a bit of how we categorize pain at 2 time points. So what we've done is that we use the 3 categories in 2007 and the 3 categories in 2014 and pretty much cross them. So our reference group are those that report lower pain in both time points. So these are kind of the best case scenario. And then we would have the extreme, the other end of it, which is severe, which is both period, they report severe pain. So that's about 2%. And then the large group in the middle are more the changes group. But I think what we clarify is that those that report low to medium or low and medium in either way, in the 2 ways, we just use it as one big group, which we break down as well. But the group that we're really interested in is the 2 group of the mean changes. What if they have severe in 2007 and low or medium? Basically, they no longer have severe in 2014, which is about 7%. And then we have the other group, which is low, medium to severe, which is more increasing pain over that period, reporting period. And these are our 5 main categories of our analysis. So we did the hierarchical models with 3 models, but I'm just going to present the last model, which is the final one, including socioeconomic demographic variables, health covariates, and also pain variables. So the both values are p less than 0.05, and the final analysis, we exclude those that have a severe functional limitations at the baseline. So these are kind of, they already have the condition. So we exclude them and only adjust it for the baseline score. So I think it's just moving a little bit, but so I might just start from the bottom. So these are only fully adjusted models. So I'll just start from the pain status first. So it's quite significantly noticeable that those are reporting a low, medium to severe pain in 2007 and then severe in 2014 were the most worse off. So basically they have a almost 4.96 increase in functional limitation scores compared to those that have low in both periods. The next group is the severe, which are also quite high, but it's noticeably that it's the one that changes to the worst one that actually worse off. Those that low, medium to low, medium, and severe to low, medium, they were having a slightly less functional limitation, but these are not statistically significant. The other one that are quite significant in the model is the having depressive symptoms, and these are what we expected in the analysis anyway, that these two groups would be associated with having the worst functional limitations. So those have depressive score, having a 4.38 more functional limitation score, and also those that have a chronic conditions. So other ones in this in the analysis, the effects of the age. The older groups, of course, as we know, they're more likely to have functional limitations. Being females, slightly having those worse off group, having elementary education, and also residing in the outer islands. So that's the outcome for functional limitations. So now we move on to the group strength, which is the similar system that we use. So again, I'm going to start from the bottom. So here is the other way around, that people that as 7 years on, they are more likely to lose their strength, basically. But if they have a low to medium in 2007 and 2014, they have severe, they're actually more likely to be associated with weaker 1.17 grip strength compared to those that are low reference. There's not statistically significant in other groups. So noticeably, those that have worse condition between 7 and 14 were the worst off group in this one. Again, they have covariates of depressive symptoms and chronic conditions were the two that also were a predictor of a group strength in 2014 with less than 1 kilogram, but it's statistically significant. The group, similarly, again, females were having a much weaker grip strength. Having an older age also affected that, and some the group that are separated divorce, and some of the lower per capita expenditure tertile, and those residing in the rest of Java. So these are significant predictors in the final models, but not as some of these are not as large as the pain after adjusting for all the covariates. So some observations of female older age group being widow and divorce, low social status associated with pain and adverse health outcomes for both functional limitation and weaker grip strength. We noted that there's a greater variance of functional limitation because of how the score are being combined. So this comes from a range of ADL and IADL covering the entire body. So in contrast to the objective grip strength, which is mainly focused on. So we also noted that initially we thought that those that are severe in both period should be the worst off group, but actually it's a significant impact of those low and medium pain in 2007 and the severe pain in 14 that are the worst off. And we think that a plausible explanation could be that these are maybe more recent in the last 7 years, and older respondents might have had less time to adjust to these functional limitations, and that impacts on the physical performance compared to those that have already been severe in both periods. So findings also point out the importance of comorbidities such as chronic conditions and also depressive symptoms when investigating pain and functional health, which is similar in the literature. So attrition in IFLS, as I mentioned, mainly from loss of follow-up from those that migrate from rural to urban areas, and these non-response groups tend to be from higher socioeconomic status. So because pain and functional health in our studies are mainly linked to those that are in low SES, so we think that this attrition bias is less likely to affect our overall findings. The main strength of our study is the IFRS data, which is a large population-based survey, and it's one of the few that have this self-reported pain in the developing economies and also in Asia. There are a couple of limitations as well, because the self-reported pain that they ask doesn't necessarily reflect, doesn't provide as much detail of whether is it come from an acute nature or chronic nature. And because, as we know in the literature, that pain among older person is quite complex. So having just snapshot of pain, sometimes it's hard to distinguish whether is this from peripheral sites or these are from a central nervous system when the pain has persisted for a long time. So we weren't able to distinguish that. Also, because we only asked, the data we only collected 7 years apart, so it was in 2007, 2014, so it was not possible to capture what happened during that 7 years period. So people can have a pain in 2010 and then it disappeared. So we weren't able to check that. So again, level of pains in the study were self-reported, but it's quite common in the international literature and then surveys, because I think pain is probably going to be difficult to do experiment on, I guess, for the human ethics would probably give us a hard time. But I think that, but as noted in the ISP definition of pain at the front, that individual, although in this group may have varying thresholds of pain, but these are still the best possible way in terms of respecting them, what they reported. But it can also subject to their biological and social cultural environment. And lastly, the interpretation of findings should take into account the interlink between aging, physical decline, and pain in cross-cultural settings in the South and Southeast Asian context. And I think what I'm meaning here is that it's not directly linked to this study, but from my previous work, working with older people in Asia, sometimes they would view aging as part of the nature, as getting old, and so for them, complaining about ache and pain is it's sometimes it's just underreported, or sometimes it's just things that it's just a different concept about pain, and I think it's just something to be mindful of. And I think this is where quantitative data might not be sufficiently addressed that. So just a bit on conclusion and the implications. So our studies highlight the impact of the longitudinal impacts of pain on functional health, and also to note the importance of monitoring pain, I guess, because there are always going to be change of status. So we only managed to do 7 years, but as the study go further on, so 7 to 14 years or 20 years, I think the pattern will start to emerge. But also we should look at this in the context of other comorbidities as well, including not only the physical part of chronic conditions, but also depressive symptoms as people get older. So our studies findings complement other cross-sectional studies. So they're not, to our knowledge, there are not many studies on longitudinal data in Indonesia, really. But there are other cross-sectional studies that are actually looking at the impact of pain on quality of life and healthcare seeking behaviors. And these are also in the form of quantitative data and also qualitative data. So that's why we think it's important that the pain research from the multidisciplinary approach should look into both the quantitative, which is the trends like in this study, but also what it means as well in qualitative data in terms of the perceptions and experience of people living with pain. And this could help minimize the barriers in seeking healthcare or management of pain among older persons. So in emerging economies in Southeast Asia, there's starting to have a new collaborative developments, which include the pilot multidisciplinary pain clinics, which with the local partner. And this is also from IASP, the International Association of Pain, Study of Pain. And the sites in Asia is in Indonesia, Myanmar, and Vietnam. So just to conclude that in an increasing aging society, population surveys could be a helpful tool, I guess, to raise awareness for screening and early public health interventions. I think this is just beyond the non-communicable disease and so on, but I think overall as a pain as a holistic measure as well, to look at how that impacts older people in different ways. That's a lot of references, which I leave it in here. And also the paper was published a couple months ago with the team. And I think I will leave it with that.